We are live now, doctor. You can start the session.
On behalf of YOSI and YOSI Oculoplasty Focus Group, a very warm welcome to all of you today for our second episode of Oculoplasty Case Presentation Series ExPresYO. Today's theme is eyelid. YOSI Oculoplasty Focus Group is one of the several arms of YOSI. And this is our team led by Dr. Puneet, and we are 6 of us. So this initiative, ExPresYO, actually arose from a casual conversation between Dr. Puneet and I on how every resident and fellow should be guided to present cases at national and international platforms, regardless of their institute or medical colleges. This is a unique initiative in the sense that every presenter is guided by a mentor, which they choose, or if that's not possible, we provide it. So making it competitive is only a secondary objective. So relax, everyone. And we have also collaborated with YoSlides team, who also share the same vision. Today, moderating with me is my co-moderator, Dr. Ananya, who is currently a consultant at Joshi Hospital, Gwalior, Madhya Pradesh, and also a visiting consultant at several hospitals in UP and Madhya Pradesh. She has done a fellowship in oculoplastic surgery at LV Prasad Eye Institute, Hyderabad. I would now like to invite her to kickstart this session by introducing our expert panel of judges. Over to you, Dr. Ananya.
Thank you, Dr. Ayushi. We have an eminent expert panel with us today, starting with Dr. Joyita Das, who's a senior consultant oculoplasty and orbit at Disha Eye Hospitals, from where she has done her long-term fellowship as well. She has also experience in working as the head of department at Chitrakoot in orbit and oculoplasty. She has several published articles to her credit and has been a reviewer in high-indexed journals. She has several awards, the recent one being the AAO award. And very happy to have you with us, Dr. Joyita. Welcome, ma'am. And welcome, Dr. Mangesh Dobekar, who is an associate medical director and senior consultant, head of orbit and oculoplasty at Sri Ganpati Nethralaya, Jalna, who has done his fellowship in oculoplasty from Shankar Nethralaya, Chennai, and has numerous publications and book chapters to his name. And his special interests are lid, lacrimal, orbital surgery, and adnexal trauma. We welcome you, sir. Dr. Roshmi Gupta is there with us too. She is a visiting surgeon at Manipal Hospital and previously was in Narayan Nethralaya, Bangalore, the head of oculoplasty. She was a former consultant at LVPI Visakhapatnam and was the first to establish this specialty service in Karnataka in 2004. She has done her long-term fellowship from LV Prasad Eye Institute and then her ICO fellowship and plastic eye surgery Texas fellowship from John Moran Eye Center, University of Utah, and has several publications, book chapters, and awards to her name in state, national, and Asia Pacific conferences. Her special interests are thyroid eye disease, pediatric oculoplasty, orbital fractures, blepharoplasty, mid-face and brow correction, and ocular oncology. Our first presenter, we have Dr. Yamini with us, who is currently pursuing her oculoplasty fellowship at LV Prasad Eye Institute, Hyderabad, who is mentored by Dr. Prerna, also an LVP alumnus, and currently working at Akhand Jyoti Eye Hospital, Bihar. Over to you, Yamini.
Thank you, Dr. Ananya. I'll share my slides.
And please switch on your video also. Dr. Yamini is currently in the train going to another center. I would request her to switch on her video if possible.
Yes, Yamini, we can see your slides, but they are in presenter mode. If you could put them in slideshow.
Yeah.
They're still in presenter. Yes, now we can see slides and you're well audible. You can start your case. Your time is 6 minutes.
Good evening, everyone. I'll be presenting the first case for today, and I thank YOSI for the opportunity so that I can be of some learn from this session from myself. So I'll be presenting an interesting case, unraveling the neutrophilic storm under the guidance of Dr. Prerna. This is an interesting case which raised many of the clinical instincts of ours and made a question that how a case can present and how we should always differentiate infectious versus any other cause leading to the presentation. So a 21-year-old female presented to our emergency department with the right eye swelling, unable to open eye with progressive swelling over 2 days. It has significantly progressed from the first day to the day she presented to us. And on eliciting the history, there was no history of trauma or insect bite. Patient first visited a local clinic where she was diagnosed as right eye necrotizing fasciitis, started on IV antibiotics, and referred here for the further management in view of its being quite a progression noted by the local ophthalmologist. On ocular examination, the BCVA was 20/20 and N6 with the vision. The anterior and posterior segment within normal limits. The eyelid findings will be explained in the subsequent slides. So as you can see, this is the image on the day 1 of the presentation. You can see there's a bulky swelling of the entire length of the upper eyelid with mechanical eyelid. And patient at this stage on the same day of the presentation started on IV antibiotic, but by day 4, what you can see is that there is an Ishar formation at the site. The edema has significantly reduced, but there's still induration, tender, and erythematous presentation. On the imaging which was ordered at the local clinic we had with us, so on evaluating that, what we can see in the mid and the posterior coronal section, that there is a soft tissue swelling in the right preseptal space. There is no extension to the orbits, and the extraocular muscles look normal. So considering all this, we came to a provisional diagnosis that it could be a necrotizing fasciitis. And considering its progression, we plan to take the patient for the wound debridement under general anesthesia, and also to send the samples for microbiology and histopathological evaluation. What we made sure at this point that when we are operating and debriding this patient, to take a sample from the involved and uninvolved site, so that the histopathological reports becomes more relatable to us, that what is the difference in the inflammatory marker in the tissue and at what level it is. So this is the first post-operative day image of the patient, where an open wound post-debridement and a collagen sheet was used to cover the open wound, and it was left to heal by secondary intention. And patient was started on oral antibiotic, tablet augmentin 625 milligram twice a day was given along with analgesics. There was no progression of the necrosis was noted. The microbiology reports were expedited at this stage, and patient was both grams and KOH was negative, which was surprising to us as well. Patient was kept on regular follow-up on the video calls and teleconsultations. At post-operative 1 week, with the culture reports came out to be negative, but what we can see with the full face and closed image, that there was a healthy granulation tissue at the area of debridement seen, and the involvement has significantly reduced. Considering all of this, what came as surprise to us with everything being negative, and we thought it could be an infectious, but it was completely contrary to what we thought at the first place, that histopathology played a role in this. And this is a 20x image, hematoxylin eosin image, showing as the first marking is being showing a ruptured blood vessel with lymphocytes surrounding it, and there is a dense neutrophilic infiltration with fibrinoid necrosis. So considering all this and making a histopathological diagnosis with the help or diagnosis of dense neutrophilic infiltration with fibrinoid necrosis, known as Sweet syndrome or periocular Sweet syndrome is being known, which is not a very common entity, but a rare entity presentation was made. As for the systemic evaluation in such cases, we even ordered a blood smear, which came out to be negative as well. So with the histopathological confirmation, we started the patient at this stage on the oral tapering steroids according to the body weight, with the 0.5 to 1.5 milligram per kg body weight. So I'll bring up to the end of how the patient presented from the first day to the after steroids. As you can see, there was necrosis on the first day. Post debridement, there was healthy granulation tissue, and by the end of 1 month, when the patient was on oral tapering steroids, the healing is excellent, and the outcome came out to be really good with minimum scarring at the debrided site. Coming to the discussion, the acute febrile neutrophilic dermatosis, which is also known as periocular Sweet syndrome, is a rare variant. What happens in this is basically an exaggerated immune response, particularly involving neutrophils, secondary to infections, even to drug reactions, most commonly being the granulocyte colony stimulating factors, systemic diseases association, hematological malignancy, more commonly with AML and myelodysplastic, inflammatory bowel disease, more commonly with Crohn's, and autoimmune disorders. And in autoimmune, more commonly an association, according to the literature, has been shown more that there is a thyroid association. No gender predilection has been noted in the literature, but predominantly in the reported cases, what we have seen is more commonly is a female predominancy. But to make a diagnosis, there's a major and minor criteria which has been given to call it as being a classic sweet syndrome, or it's being a drug induced, or it being a malignancy induced. So classic includes two major, so to confirmation, and out of the four, two should be there to call it as a classic sweet syndrome. The collagen sheet which we use in this patient has its own significance, as it is a biomaterial which is used for skin and corneal wound healings, and it helps as a as it provides an equal environment as that of the normal skin as it displays, and helps in better wound healing with the minimum scarring at the debrided wound site. Coming to the last, as how differentiating an infectious presentation from what we had in this. So whenever there's a necrotizing fasciitis, the presentation will be more painful. The involvement will be of the deeper tissue in comparison to what we didn't saw in sweet syndrome. And the treatment is very contradictory in two cases, where steroids being contraindication in the if it is an necrotizing fasciitis, whereas the treatment of choice is being the steroids. So with this, I would like to conclude with a take-home message that it's very close mimicker of necrotizing fasciitis and also of orbital cellulitis. And we should always revisit our diagnosis whenever we are not able to find a improvement when the patient started on antibiotics. Always check for the systemic involvement is there, or any inciting events, which sometimes miss when we lack at the end of taking history. But the diagnostic of this kind of presentation is a histopathology. Thank you.
Thank you, Yamini. That was a mind-boggling case. I would like to invite questions from our judges, Dr. Mangesh. Yes, Dr. Mangesh, would you like to ask Yamini any questions about the case?
Yeah, really good presentation, Yamini, and really it's a rare case presentation. We see necrotizing fasciitis, but it was surprisingly turning out to be a sweet syndrome. In a histopathology, you mentioned there was a lymphocytic infiltrate around the blood vessels. Is this a typical finding in the sweet syndrome?
No, Dr. Mangesh, it's not a typical finding, but after this case presentation, we had 3 or 4 more cases which we had similar to sweets, and they did have the presentation to similar to this. But on the literature basis, we didn't had any specific that there's a ruptured blood vessel surrounding it, but it was there because it is also present in the cases of necrotizing fasciitis as well as in this.
Yeah, because I think vasculitis is not a component of sweet syndrome.
No, it's not a component.
Okay, and just a very short question. Had it been a necrotizing fasciitis, is how it would change your line of management?
So till the debridement, it would be same, and we would have continued the patient on the antibiotics. Yes, we would try to rule out what is the cause which was leading to the necrotizing fasciitis. Is there any systemic involvement which was there? If it is there, we will try to address this along with the involvement of a physician if anything needs to be addressed. And the inciting factors which is causing necrotizing fasciitis has to be addressed if it is necrotizing fasciitis.
Okay, and what would be the common microorganism you encounter in the NF?
What I can recall most commonly is Streptococcus is being the most common organism involved.
Yeah, because we should be very well aware about the proper treatment of the necrotizing fasciitis, and sweet syndrome and all these things are there, but these are comparatively rare. So common things should come. And you have described it very well. Thank you for the case.
Thank you, Dr. Mangesh.
Thank you.
Dr. Joita, would you like to ask a question to Yamini?
Very nice case presentation, very well documented. So what do you think the most, the striking point where you came to the diagnosis that it is Sweet syndrome, not necrotizing fasciitis. So is it histopathology?
Yes, ma'am. What till the time we didn't have histopathology, the first different thought was always a necrotizing fasciitis. But because by the time we have grams and KOH also being negative, we were again confused that if it is also negative, then there is no infectious cause as of now. So we even expedited the culture reports, which again came out to be negative. And by that time, we had histopathology, which made us confirmatory with that yes, it's histopathology being the main reason with which we come to the diagnosis of sweet syndrome.
How long the oral steroid continued? The duration
Ma'am,
of
we
the
started
steroid
for a duration of, yes, we gave it over a duration of 6 weeks at a tapering dose according to her body weight.
Any topical steroid?
No, ma'am,
Any
no topical
topical?
steroids were given. No,
Only
ma'am.
dressing.
Yes, ma'am. There was collagen sheet which was used in
Okay.
initial when she was admitted, and after she was discharged, the collagen sheet was left there, which was there, and it healed on its own. There was no other ointment application or anything was there.
Okay. Thank you. Nice.
Dr. Roshni, would you like to add any comments?
Yeah. Dr. Yamini, lovely presentation. So if we go back to the initial presentation, when you first saw the patient, what would trigger, question one is, what would trigger your suspicion that this is not a run-of-the-mill infection? Okay, it's not a preseptal cellulitis. It's unlikely to be a necrotizing fasciitis. So what would be your suspicion, how would your suspicion be triggered about that? And B, what would be your thoughts of what are the other things that can cause this kind of a necrotizing picture in the preseptal area?
So, ma'am, if I'll say I was the first person attending this patient in emergency, my first was that it could be a preseptal cellulitis. That is what I thought when I encountered her. Second, I thought that it could be orbital cellulitis, but all the points which we differentiate from preseptal to orbital were not there. These were the two things. So we started on the IV antibiotic because from the day she showed me the fit pictures on the first day of presentation, for the first moment to the time she came.
So
As
at
it was
this point
progressing,
of
so we
time,
started
has
on the IV.
anybody, did you have available any CBC, leukocyte count, neutrophil count?
Yes, yes, ma'am. I had at the local clinic where she visited. They requested the complete blood count, which was normal. The ESR was raised in this patient.
Okay, so that would
But
probably
the
be
WBC
your
count was
first
not
red
raised.
flag that this is not a typical preseptal cellulitis at all. Because if it's a cellulitis,
Yes.
bacterial
Yes.
cellulitis, you'll have your WBC raised, right?
Raised, yes.
Okay,
Yes.
so now let's talk about what other things can cause this kind of necrosis, kind of avascular necrosis.
It could be secondary to insect bite, which I tried to rule out, but there was not there. And
Okay.
it like what I could understand that it could be secondary to some of the hematological malignancies as well, which were not diagnosed or presenting for the first time, as the ocular involvement being the first. Secondary to inflammatory bowel disease like Crohn's being undiagnosed for years, and patient has been repeated episodes of conjunctivitis, scleritis, and sometimes the first presentation is being this.
Okay,
In the
so
system,
supposing you're not talking about sweet syndrome at all, you're just talking about an eyelid with necrosis like this.
Diabetes being the most common cause, ma'am, presented.
Okay.
Like deranged blood sugar profile will be there in those patients.
And among the microbiological infective agents, what would cause this kind of an avascular thing, kind of eating away at the eyelid?
I'm not very sure, but I think it could be.
Yeah, go ahead.
Yeah, I'm not sure, but I think. No,
Dr. Prerna, would you like to pitch in? We have her
I'm not sure.
mentor also. Dr. Prerna, are you there?
Hello, Ayushi, am I audible?
Yeah.
Hello.
Yes, you're audible.
Yeah. So cases with necrosis, I think even a fungal infection can cause such necrosis. So maybe that also should be kept in mind, and we can treat the patient on those lines.
Absolutely. That would be, the correct way to proceed. That would be the one that you followed, where you went ahead and debrided all the unhealthy tissue and sent it for microbiological assessment. So well done, Dr. Yamini.
Thank you.
Thank you, everyone. Thank you, Yamini, for such an interesting case. Moving on to the second case, we have Dr. Devika with us, who is currently a fellow at Sadhguru Netra Chikitsalaya, Chitrakoot, who's mentored by her head of Department of Oculoplasty, Dr. Narendra Patidar. Can we have Dr. Devika, please? Dr. Devika, you can share your screen.
Yeah, I would request all presenters to share the screen as soon as the previous presenter unshares so that we can save time. Devika, please share.
Dr.
Yeah,
Devika,
your screen is
slideshow. Yeah.
Are my slides visible?
Yes, they are. You can go ahead.
Am I audible?
Yes, you're audible. Be mindful of the time. It's 6 minutes.
Please start.
Yes. So, good evening, everyone. First of all, I would like to extend my sincere gratitude to YOSI for granting me the opportunity to present on this esteemed platform. Today, I'll be presenting a case titled An Eyelid Mass with a Memory, Revisiting a Recurring Lesion. A 69-year-old female presented to us with the chief complaints of mass regrowth in the right eye lower lid for 2 months, which was progressively increasing in size. There was history of mass removal from laser multiple times elsewhere for 2 to 3 years. She underwent excision biopsy in April 2023, which revealed mucin-producing endocrine sweat gland carcinoma. Then again after 2 months, she noticed recurrence of mass, which was gradually increasing in size. Then she reported to our department in September 23. Additionally, the patient had a significant oncologic history of left modified radical mastectomy with axillary clearance 28 years back, for which the histopath was suggestive of infiltrative duct carcinoma of breast grade 3. She is a known case of type 2 diabetes for 4 years under treatment. On examination, the right lower lid exhibited a pinkish sessile, non-tender nodular mass measuring 11 into 3 into 2 mm, present at the right lower eyelid margin, not involving the puncta, causing mechanical ectropion with mild abnormal vascularity. There were disrupted lid margins with madarosis. Posterior extent of the mass was visible. Lacrimal sac area was within normal limits. Anterior and posterior segments were within normal limits. Left eye findings were unremarkable. There was no evidence of regional lymphadenopathy, and the systemic examination was within normal limits. So we made a provisional diagnosis of right eye lower lid recurrent sweat gland carcinoma and sebaceous gland carcinoma. The patient underwent right eye repeat excision biopsy with 4 mm clear margins with Hughes lower lid reconstruction, with anterior lamellar reconstruction, with advancement flap. The patient was counseled regarding the loss of right lower lid canaliculi and watering post-surgery. PET scan with an oncologist opinion to rule out systemic metastasis was suggested, but the patient denied it. Coming to a brief description of Hughes procedure, it is a two-stage technique for reconstructing full-thickness lower eyelid defects. In stage 1, the defect is measured and a tarsoconjunctival flap is created from the upper lid. This flap is elevated and attached to the lower lid tarsus. A myocutaneous flap is then advanced and sutured to it. 6 weeks later, in stage 2, the flap is divided, any excess tissue is debulked, lower lid margin is reconstructed by suturing conjunctiva to skin, and upper lid is closed directly. So histopathology reports were suggestive of stratified squamous epithelium with underlying nodular tumor composed of lobules of solid cystic areas showing malignant cells in cribriform pattern, pseudo-rosettes, and small papillary architecture. The solid areas were surrounded by few cystic spaces lined by atypical cells showing micropapillary pattern with lumens showing mucin. The tumor cells were shown to invade the tarsal plate. Additionally, there was no perineural invasion, no lymphovascular invasion, and the growth pattern was nodular. So the final histopathological diagnosis was adenocarcinoma favoring mucin-producing sweat gland carcinoma of right lower eyelid, and margins were free of the tumor. immunohistochemistry was further mandatory for its confirmation and to differentiate it from metastatic adenocarcinoma of breast. So immunohistochemistry, the cells showed GATA3, ER-CK7, BRF4 positive. IHC features favors primary adnexal lesion of endocrine mucin-producing sweat gland carcinoma over metastatic carcinoma of breast in a known case. This is the post-op day 1 of the patient after Hughes stage 2 procedure showing well-formed right lower lid. And at 1 year follow-up, the patient was doing well with no signs of reoccurrence. Coming to the discussion, so endocrine mucin-producing sweat gland carcinoma is a rare tumor of sweat gland origin with a predilection for periocular skin of elderly women in the 6 to 7 decades. Histologically, it is similar to mammary solid papillary carcinoma and is considered as being a precursor of cutaneous mucinous carcinoma and has potential for local recurrence. It has an indolent clinical course and favorable prognosis. Zembovic et al. In a case series described lower eyelid to be more frequently involved. Clinically, it presents as a slowly growing skin-colored nodule. It can be cystic, pigmented, or multiple. Most of the cases showed consistent reactivity for CK7, EMA, ER, and PR, but were negative for CK20. Synaptophysin has been found to be more sensitive. Several studies showed a strong relationship between this tumor and invasive mucinous carcinoma. As quoted by Zembovic et al., EMP-SGC cases were associated with invasive mucinous carcinoma in 6 out of 12 cases. Genetic profiling may aid in distinguishing this tumor from metastatic breast carcinoma, particularly in mucin-rich or ambiguous cases, but further research is warranted. Management is ideally a Mohs micrographic surgery or a traditional excision with clear margins. Complete excision of the lesion is necessary to reduce the risk of recurrence. So in a case series, Mohs micrographic surgery had a lower incidence of recurrence as compared to surgical excision alone. So it has a favorable prognosis and since it's a low-grade neoplasm, it rarely metastasizes with excellent long-term outcomes. So my take-home message is EMP-SGC is a rare but distinct neuroendocrine sweat gland carcinoma with low-grade behavior and mammary-like features requiring histological recognition and complete surgical excision with clear margins to prevent progression and recurrence to invasive mucinous carcinoma. Thank you.
Thank you, Dr. Devika. That was an excellent presentation and very good outcome. I would like to invite Dr. Roshmi to ask questions to Devika here.
Lovely outcome, Dr. Devika. It looks beautiful. So, Dr. Devika, why don't you go ahead and teach us a little bit? If you go back to the slide with your IHC tests, what does each of that indicate if it is positive or negative? Okay. Because we are not pathologists, and
Yes,
I'm presuming that you would have discussed this case with your pathologist. What would CK7 indicate? What does BREP4 indicate?
So, ma'am, basically all these cells, they were sensitive for these markers, immunohistochemistry markers like GATA3, ER, and CK7, BRF4. And it is very much sensitive for our current case scenario. Like GATA3 is expressed in the epithelial cells in the breast tissue, and it's a
That is
subtype
what
of
I'm
breast
asking
cancer.
for.
And again, BRF4 is also sensitive for it. And CK7 is again sensitive for these kinds of tumors. So basically, it was.
Okay, so no. So you're saying you just now said GATA3 and BREP4 are sensitive for breast cancer. So if they're positive, why are you saying this is not a recurrence from the sear breast and so on? So do you get where I'm going? How did this set of IHC help you to differentiate between a metastasis to
We didn't come to
Carcinoma.
metastasis because it was a chronic time period of 26 to 28 years for which she had undergone the mastectomy procedure.
No. We've seen metastasis even after 10 years or 15
Yes,
years.
yes.
That's different. But we are talking about right now, what I wanted to learn was the indication for each of these immunohistochemistries. So it's okay if you don't know them, but it is good practice whenever you do any pathological tests, any immunohistochemistry, you go ahead and speak to your pathologist. They'll
Right,
really
ma'am.
be able to guide you, telling you, because each test, when they do an immunohistochemistry, each test has a very specific significance.
Right, ma'am.
Thanks.
Hello. Good evening, ma'am. Just I would like to come in.
Yes, sir. Yes, sir. Tell me.
Ma'am, we discussed with histopathologist, and she mentioned that we need to differentiate it if we would like to differentiate it from primary metastatic secondary metastatic lesions. So we need to do the immunohistochemistry. That's the primary aim of doing this immunohistochemistry, to differentiate it from metastatic lesion.
Thank you, Dr. Patidar. What I was getting at is the knowledge for us also is immunohistochemistry A indicates cell of origin connective tissue. P indicates epithelial tissue like carcinoma and so on. Okay, so for us also it is important to know what each of these tests indicate.
Right.
Yeah, and to add one thing, ma'am, these are the ISC marker, that is GETA3, ER, CK7, and BER EP positive. These are all positive in both the cancers, like EMG, SDC, and metastatic adenocarcinoma. So difference between them by immunohistochemistry, we have to test for the neuroendocrine marker like synaptophysin and chromogranin, and another one is, I think, INS1 or something. So if these are positive, then it goes in favor of endocrine mucin producing suet gland tumor, primary tumor. And if it is positive, then we have to think of metastatic breast carcinoma. Then comes the roles of some myoepithelial marker, which are usually preserved in endocrine mucin producing tumor, right? Like SMA, P63, and another one, there is calcitonin, no, calcitonin, such like that. So do you only these four marker, these are positive in both. So to distinguish between these things two, the other things actually come into play. But one thing favorable according to the histopathology is here the papillary pattern. In her case, Devika presented the microbiology that a papillary pattern and the luminal mucin, it goes favorable to the endocrine mucin producing. So immunohistochemistry here actually not confirmatory. So we need to do those things.
Thanks for helping out, Dr. Joyita.
Yeah.
So, Dr. Devika, this is where we come to, right?
Right.
Very nice presentation.
It's
Very
like,
nice.
your chemistry class in high school. You run different kinds of tests to differentiate the compounds.
Right, ma'am.
Nice
Thank you, Dr.
presentation.
Roshmi and Dr. Joyita, for telling us the importance of IHC. Dr. Mangesh, would you like to give any comments? Dr. Mangesh, you're muted.
You're muted.
Yeah, Devika, excellent presentation.
Thank you, sir.
And just going back to the basics, what are your differentials, primary differentials?
So since she got operated outside first, and the histopathology was itself there was suggestive of endocrine mucin producing sweat gland carcinoma, so we kept the provisional diagnosis of the same and sebaceous gland carcinoma. We kept sebaceous gland carcinoma as a diagnosis because since the histopathology was previously was done outside, but we didn't analyze its blocks. So therefore, these two were the provisional diagnosis for this particular case.
Okay. And the surgery performed, it was a one stage or the two staged?
It was a two-stage procedure, sir.
Okay.
Huge stage. Huge procedure.
Was it a frozen section control?
And for histopath, sir?
Yeah.
Fasting chal raha hai.
Frozen section control?
I'm not sure about that.
Intraoperatively, you did frozen section for the margins?
Dr. Narendra, would you like to comment?
I'm not sure.
Yes, sir. It is not the frozen section control margins
Yes, sir.
clearance. So for actually we have to send the biopsy outside, and which requires the report to come up after 3-4 days. So we actually plan for reconstruction as a delayed reconstruction procedure. So
Okay, just my point was that if it is a really a locally invasive tumor, then would it be a better idea to wait for the penumbral sections or the reports to come and then go for the
yes,
once the margins are clear,
yes,
then
sir.
we can
Usually
go for
we wait for the margins clearance and then we reconstruct. So it will take 2-3 days.
okay.
So it is a delayed kind of reconstruction.
And was the patient on treatment for the breast carcinoma?
No,
Any
sir.
details?
No,
Any
she
details?
was not on any specific.
Because usually these patients are on the long-term chemotherapy, oral chemotherapy. Patient not receiving anything?
Yes, sir.
Patient was receiving any oral chemotherapy regimen? Any idea?
No, sir. She didn't.
Okay. Okay, good case.
Thank you, Dr. Mangesh, and thank you, Dr. Narendra. This was a wonderful case. I would like to ask if you could give any tips to us beginner surgeons. It was a very beautiful outcome with Hughes.
Yes, Dr. Yam. So actually, Ukes and all, usually we should be plan for mostly the central defects only. So although it was a little bit of medial defect, so though we tried and plan for this Hughes procedure, and we found that the lower lid anterior was legs, so we could achieve this anterior lamellar reconstruction with advancement flap only. And in this, actually, the canaliculi we have to sacrifice. So we already explained the patient regarding canaliculi, and we try to extrude those this cut end of canaliculi.
Thank
So sorry, so sorry to interrupt. There was any part of tarsus available in the lower lid?
Yes, sir. Laterally, it was available.
Okay. Inferiorly?
Inferiorly, no, sir. No.
Medially, inferiorly, no.
No.
Okay. Excellent outcome, sir. Thank you for
Thank
sharing.
Thank you, sir.
Dr. Narendra, how do you know when do you want to take glabular flap versus paramedian forehead flap or the advancement flap?
So as I mentioned, the medial defect can be in this patient also. We could have done the glabular only, but those glabular flap is mostly for the medial most defect.
Right.
Yeah.
Thank you
It
so
was.
much.
Yeah. Thank you.
Thank you so much, Devika. You can unshare. That was a wonderful presentation. We have one more candidate from Sadhguru. We have Yashodhara Singh coming up next, who is a fellow in orbit and oculoplasty, again, mentored by Dr. Narendra Patidar at Sadhguru Netra Chikitsalaya, Chitrakoot. You can share your presentation, Yashodhara.
Yes, ma'am. Are my slides visible, ma'am?
Yes, they are visible and you're well audible. You can start.
Good evening, everyone. First of all, I would like to extend my sincere gratitude to YOSI for granting me the opportunity to present on this esteemed platform. Today, I'll be presenting a case titled Orbital sarcoidosis with overlapping autoimmune features, a rare diagnostic challenge. Sarcoidosis, to begin with, the literature suggests that sarcoidosis often develops autoantibodies associated with other autoimmune diseases, even in the absence of clinical features of those conditions. This overlap can often complicate diagnosis and delay the targeted treatment. So to begin with the case, a 24-year-old female with a known history of hypothyroidism presented to us on December 27, 2024, with a 10-month history of bilateral upper eyelid swelling associated with pain and redness. She had been on oral steroids prescribed elsewhere for about 7 months and had reported complete improvement on left side. On clinical examination, she had an S-shaped swelling of the right upper eyelid along with mechanical ptosis. While her extraocular movements were full, retropulsion tested positive with a difficult finger insinuation in the right eye. Left eye examination was unremarkable. The MRI of the orbits were done elsewhere, showed a homogeneous soft tissue mass in the anterolateral orbit with significant lacrimal gland enlargement with no evidence of any bony erosion or adjacent tissue infiltration seen on coronal and axial sections. Based on the clinical and imaging findings, our initial differential diagnosis included right eye dacroadenitis, idiopathic origin. Specific causes included sarcoidosis, IgG4-related disease, and vaginous granulomatosis. Others included lymphoproliferative disorder. To refine the diagnosis further, we ordered a systemic workup. Interestingly, 3 key serological markers were found to be elevated. The patient's lab results showed raised serum IgG4, high angiotensin-converting enzyme levels, and a positive rheumatoid factor positivity. Additionally, the ESR was elevated and chest X-ray showed hilar congestion. Rest all other findings were within normal limits. For histopathological diagnosis, an incisional biopsy of the right lacrimal gland was performed on February 3, 2025 through a lid crease incision. Biopsy revealed non-caseating epithelioid cell granuloma seen with surrounding areas of fibrosis suggestive of granulomatous inflammation of the lacrimal gland. A rheumatology consultation was obtained and a high-resolution CT chest was advised. The HRCT revealed positive paratracheal lymph nodes measuring 5 to 9 mm in size with parenchymal and pleural thickening, especially over the right middle lobe. We arrived at a final diagnosis of right eye orbital sarcoidosis with systemic features and overlapping serology. The patient was then started on oral methotrexate as a steroid-sparing immunomodulator along with tablet methylprednisolone 4 mg as advised by the rheumatologist. The patient followed up in May 2025 with reduced lid edema and marked reduction in size of the upper eyelid swelling. Schirmer's 1 measured 17 in the right eye and 25 in the left eye. Patient was symptomatically better and is now on regular follow-up with the rheumatologist. These images depict the patient before and after treatment. So moving into the discussion part, where the findings in our case closely parallels those reported by Katie et al., where all patients with orbital sarcoidosis demonstrated non-caseating granulomas on histopathology, highlighting the presence of fibrosis and lymphoplasmacytic infiltrates. Additionally, study also demonstrates IgG4 plasma cell infiltration, identifying 1 case with elevated IgG4 levels, suggesting occasional overlap with IgG4-related disease, much like our case where raised IgG4 and autoimmune markers was observed. This underscores the diagnostic challenge and importance of distinguishing between sarcoidosis and IgG4-related orbital inflammation. Our case also mirrors the findings of Judson et al., who reported co-occurrence of sarcoidosis with connective tissue diseases, particularly in female patients. As mentioned earlier, our patient had hypothyroidism and showed rheumatoid factor positivity. Similarly, Judson's cohort included individuals with rheumatoid arthritis, SLE, and other autoimmune conditions. Also, the retrospective study by Shi et al. Identified Hashimoto's thyroiditis as the most common coexisting autoimmune disorder in patients with sarcoidosis. This mirrors the background of hypothyroidism, reinforcing the frequent association between sarcoidosis and thyroid autoimmunity, supporting the concept of immune overlap and highlighting the need to screen for coexisting autoimmune conditions in such presentations. This case underscores the importance of a multidisciplinary approach and thorough systemic evaluation when encountering atypical ocular or periocular inflammatory presentations, particularly those unresponsive to standard steroid therapy. Thank you.
Thank you, Yashodhara. That was an interesting case. I'm sure a lot of us face such kind of orbital inflammation involving the lacrimal gland. I would like to invite questions from Dr. Joita here.
Nice case presentation. First, when you made the see the patient first, what was your primary differential diagnosis?
Ma'am, when we first saw the case for the first time, it was dacroadenitis. which usually presents with the right eye, which usually presents with the lid swelling on the lateral aspect, and could be an orbital inflammatory disorder.
Was it painful? Is there any pain or tenderness? Present
Yes,
any
ma'am.
tenderness?
Yes, ma'am.
It was
There
there.
was tenderness and pain in the right eye.
Okay. In our country like India, why don't you think that it could be tuberculosis?
It could be
First.
tuberculosis.
Yeah.
In the present case, the patient tested negative for tuberculin test, Montague's test, and TB Gold. Ma'am.
Okay, right.
Dr. Roshmi, would you like to ask her a question?
Dr. Yashodhara, very well managed case. So, would you share with us your protocol for approaching a dacryoadenitis, a lacrimal gland swelling? What's your protocol?
So, any case of dacryoadenitis would be managed first with we'll start off by giving steroids as a first line therapy, and second line of therapy can be any immunomodulator such as mycophenolate, azathioprine.
Let me interrupt you. When we are talking about management, I'm not talking only about the treatment. I'm talking about the approach. In this case, you did do a biopsy.
Yes,
so,
biopsy.
In which cases do you do a biopsy? Which cases do you just start off with oral steroids? How would you decide that? Do you do a biopsy for all cases? I mean, I'm just wanting to know your protocol. How do you go about it? How do you write this entire set of tests for everybody? How is it?
We order these set of tests so as to come to a specific diagnosis. The cause could be idiopathic, but if we want to come to a specific diagnosis, like sarcoidosis, lymphoma, or IgG4 or Wegener's, so we need a histopathological diagnosis. So in order to do that, we order for a lab particular all the tests that we have ordered.
Great. And obviously the biopsy. So yes, at first presentation, do you ask for biopsy for all lacrimal gland swellings?
Ma'am, for lacrimal gland swellings, we would require a biopsy in order to come to a specific diagnosis, in order to come to a specific cause for the dacryoadenitis, whether it is sarcoidosis, it's tuberculosis, or what's the specific cause. So we would like a biopsy for that.
Would you help her out, please?
Yes. So first, I think we need to rule out the infection. So after ruling out the infection, if we are suspecting the inflammation, then probably the approach may be different. Some people may prefer biopsy first, and some may prefer steroid first. So as this case is already taking treatment elsewhere, and since 7 months. So after 7 months, there is recurrences and relapses. So we would think that we should go for biopsy and see if there any other cause for recurrences and relapses.
Absolutely, Dr. Narendra. So Dr. Yashodhara, that's what Dr. Narendra, that's what made him decide that, the patient needs a biopsy.
Right, ma'am.
Patient has received steroids and kept recurring.
Right, ma'am.
That's why a specific diagnosis was necessary.
Right, ma'am.
Dr. Mangesh, I wanted to know your protocol at Jalna Institute, Ganpati Nethralaya, because as Dr. Rashmi and Dr. Narendra pointed out that different surgeons approach lacrimal gland swellings differently. Some may do steroids first versus some may do biopsy first. So is there any specific, are there any specific swellings for which you do biopsy first and any specific ones where you go for lab with the steroids?
Yeah, in this regard, I totally agree with Dr. Roshmi and Dr. Narendra. But many of the times what happens whenever you ask the patient to go ahead with the incision biopsy at the first go, most of the patients are not ready. It's very difficult to convince them at the first go. So just in this case, Dr. Yashodhara, was the patient on the steroids at the time
Yes,
of biopsy?
sir, the patient, not at the time of biopsy, but when she presented to us in December, before that, she was on steroids for 7 months. And we had stopped steroids after that for 3 weeks so that there's a washout of steroids. And then we proceeded with the biopsy.
Yeah. Yeah, many of the times this happens that many of the patients, they even elsewhere they receive the steroids and the recurrence happens. And then it is very important, if there is a recurrence, then we should go ahead and should have a broader view. If there is any associated systemic features that fits into the any specific inflammatory disorders or the vaginous granulomatosis or the sarcoidosis or India being endemic for the TB or the tuberculosis. And I would keep a very low threshold for the biopsy in all such cases, because many of the times patients become very happy after giving a trial of steroids even if for the 6 weeks, and they want just give me that wonder drug again so that I will be happy. But we should not follow that protocol. As usual, we should have a very low threshold for the incision biopsy. And even in the first go, when I'm just once I've ruled out the infectious part, I actually incise them on for the incision biopsy.
Absolutely. Thank you so much. We'll move ahead in the interest of time. And I would now like to invite the next presenter, Dr. Haig, who is currently doing her senior residency at RP Center AIMS. She has been mentored by Dr. Sahil Agarwal, who is here with us today. He is the assistant professor in the Department of Oculoplasty and Oncology Services at RP Center AIMS. Over to you, Dr. Haig. We can see your slides, but yeah, it's on slideshow.
Yes, ma'am.
Start.
Good evening, everyone. Today I'll be speaking on the costly affair of an eyelid itch. There is no financial disclosure. We have a 57 years old female with a complaint of itching of the right eye upper lid since the past 6 months, associated with mild redness and loss of lash, but there is no history of any allergy. The patient was doctor shopping and was managed previously as a case of recurrent blepharitis, but there was no improvement in her symptoms, so she came to our OPD from where she was referred to the oculoplastic clinic. On examination, we found that there is lid margin distortion with mild thickening of the margin as well as loss of the lash. On eversion, we saw that there is mildly congested palpebral conjunctiva. Based on our examination and the clinical features of the patient, due to the recurrent unilateral blepharitis-like picture in the upper lid in a middle-aged female, 57 years old, with features of loss of lash, distortion of the lid margin, mild thickening of the lid, we came to a provisional diagnosis of sebaceous cell carcinoma. But points against this diagnosis was there was no palpable mass or there was no visible yellowish nodule seen. Next, it can be a chronic case of chronic blepharitis, or there could be any infectious etiology. Due to our high suspicion of a sebaceous cell carcinoma, we underwent a biopsy. So, to our surprise, the biopsy did not reveal any malignancy. Rather, it showed a non-caseating granulomatous inflammation. So, based on these histopathological findings, we kept the DDs of tuberculosis, sarcoidosis, vaginous, fungal, and idiopathic inflammatory pseudotumor of the eyelid. We went ahead with a complete systemic workup of the patient, where the complete hemogram, LFT, RFT, and the inflammatory markers were mostly within normal limit, and the systemic examination was also within normal limit, except for the raised DSR and a chest X-ray, which was positive for a bilateral asymmetrical hilar lymphadenopathy and a positive Montauk's. Now, from all these findings, we had ruled out the vaginous as well as the fungal infection based on the based on the findings. Our suspicion for tuberculosis was still high, since our country is an endemic country for TB, which revealed, and the HPA revealed a non-caseatic granulomatous inflammation with a raised ESR, positive Montauk's, and bilateral asymmetrical hilar lymphadenopathy. Since our suspicion was high, we went ahead with a gene expert investigation, but still it came out as negative. So with all our hopes went away there was no particular features which was favoring TB, we went ahead with a pulmonary medicine consultation. So, on repeated history taking by the pulmonologist, the patient revealed that there was dyspnea present on exertion. So, the pulmonologist, they went ahead with a pulmonary function test, and which revealed a mild restrictive lung disease, which gave us hope for reaching towards the diagnosis. Now, they ordered for a HRCT chest, which revealed bilateral micronodules, thickened septa, and ground glass opacities. Then the pulmonologist ordered for a transbronchial needle aspiration from the mediastinal lymph node that we had seen previously using the endobronchial ultrasound, which revealed again a non-chisating granulomatous inflammation. Based on all the clinical radiological features and the histopathological results, we came to the diagnosis of sarcoidosis. And the pulmonologist had started the patient on steroids with a tapering dose. In a 1-month follow-up, the patient's or the itching complaint had completely waned off. And there is decreased redness, there is decreased lid swelling, there was regrowth of few lashes, and the pulmonary function test had also improved. A prompt magical response to the systemic steroids also supported the diagnosis of sarcoidosis. So coming on to the discussion, sarcoidosis, as we all know, it is a chronic non-chisating granulomatous inflammatory disorder of unknown etiology. Ocular involvement usually occurs in 20 to 30% of the cases. The most common ocular manifestation is uveitis, and the most common orbital manifestation is dacryoadenitis. Sarcoidosis of the eyelid is a rare entity. It happens in the skin is actually maybe involved in only 12 to 20% of the cases. The eyelid manifestation usually include diffuse swelling, severe distortion, eyelid scar, eyelid retraction, millet seed nodules or ulcerated nodules, and rarely lupus pernio plaques. Conjunctival involvement is also common in sarcoidosis. So coming on to the diagnosis and management, there is no single gold standard diagnostic test for sarcoidosis. It is based on the American Thoracic Society definition that there should be a compatible clinical radiological finding, histological evidence of non-necrotizing granuloma, and we should be ruling out other granulomatous causes. The management is usually done with corticosteroids. In resistant cases, we may need to add immunosuppressants. Once the active inflammation has been controlled, surgical reconstruction may be successfully performed in case of gross distortion. So the takeaway points from my case, it is the patient history fits the best, never ignore it. An ophthalmologist can play a crucial role in early diagnosis of an underlying systemic disease. Sarcoidosis can never stop amazing us. I would like to highlight that from the initial diagnosis of blepharitis to a subsequent suspicion of sebaceous cell carcinoma, tuberculosis, and sarcoidosis, this persistent eyelid itch, it followed a turbulent course before reaching the final diagnosis, making it a prolonged and costly affair. Thank you.
Thank you so much, Dr. Hake. I completely agree with your last point that sarcoid can never stop amazing us. And I feel that it is more common than we think. Even I got one case of sarcoidosis 2 weeks ago.
Okay.
So, yeah, excellent presentation. I would now like to request Dr. Mangesh to ask Dr. Hake a few questions.
Excellent presentation, Dr. Hake.
Yeah, thank you.
And I really agree with Dr. Ayushi. Sarcoid never stop amazing us. And on this context, I would like to even ask a question to Dr. Roshmi Gupta rather than Dr. Age. How do you think when sarcoid is taking a place than the other autoimmune disorders? Is it coming as one of the commonest disorder you see?
It's not quite the commonest yet, but the point being, say 20 years ago, we used to imagine that sarcoidosis doesn't happen in India. But that was a function of not doing enough biopsies and not doing enough tests.
Correct. Totally.
So I think when we are talking about inflammations, it is a question of being as systematic as possible.
Yes.
Not to presume things.
Yeah. So Dr. Age, you have nicely worked up this case right from the initial presentations, and you have kept the primary differentials of the sebaceous gland carcinoma, maybe pegyatoid spread.
Yes, sir.
And were you thinking of taking congenital map biopsy also in this case?
Sir, not as such in the primary biopsy. If it later on it came to be a sebaceous cell carcinoma while doing the late reconstruction, that time we may have to take the map biopsy.
Yeah. And after that, you did the relevant investigations.
Yes, sir.
What relevant investigations were in support of sarcoidosis in your case?
Sir, in our the histopathological finding, the raised ESR and the bilateral hilar lymphadenopathy in the X-ray. So there was a Montaux positive, but that can be explained that any of us can have the Montaux positive.
ACE titers were also high?
No, ACE was not raised. It was borderline, like just below.
Okay, good. And you have taken that endoscopic biopsy also? That also confirmed your
Yes, sir. Yeah.
sarcoidosis. This is the way how should one should go ahead with the inflammatory protocols.
Yes, sir.
When you are suspecting anything, like we should not presume, like Dr. Roshni has rightly said, we should have a proper protocol in reaching of the final diagnosis. Good,
Yes.
excellent presentation.
Thank you, sir.
Thank you, Dr. Mangesh. Now I would like to ask Dr. Joita to put forward some questions for Dr. Haig. You muted, Dr. Joita. Yeah.
Very nice case presentation. I think she has done is very systematic way, and she didn't lift any stone unturned. So very nice. Thank you.
Thank you, ma'am.
Dr. Roshmi, do you want to ask any questions to Dr. Haig?
Yeah, true. Dr. Haig has sort of plugged all the leaking points.
Thank you, ma'am.
Well done.
Thank you.
Do we have Dr. Sahil here? He was there a few minutes ago. Is he there? Okay. I wanted to ask any of the judges, what is your protocol for ruling out TB? Like, do you do PCR in all cases, or you do quantiferon for all cases other than Monto and chest X-ray? Or Dr.
Okay.
Roshni?
If I go first, so what's been seen is that quantiferon is not that specific in picking up ocular adnexal tuberculosis. It's not that good. And as Dr. Haig also mentioned, that Monto can be positive in any of us. So ultimately, it goes down to the histopathology, and then on that, the PCR on that, possibly the gene expert. But I would also, ask for the other mycobacterial PCRs at the same time, not only MTB.
Like you mentioned that to rule out other mycobacterial infections, is it?
Correct.
Okay. Dr. Mangesh, Dr. Joita, do you...
Same specimen, both to be done at the same time.
Got it. Yes, Dr. Joita, do you do anything different? Dr. Mangesh?
Yeah, especially first the histopathology should give us a clue, and then we should go ahead with the PCR TB. While doing the PCR TB, we actually don't neglect the quantiferon and Montaux. These are the supportive things, but these are the non-specific ones. So histopathology and the PCR TB would be my take.
Thank you. Dr. Joita, what about you?
Same histopathology and PCR equivalent.
Thank you.
So and quantiferon TB gold is not specific. It is might be sensitive, but not specific.
Okay. Thank you so much. We'll move to our next presenter, last but not the least, Dr. Savni Dole. She's currently doing her second year residency in ophthalmology at ACPM Medical College and Hospital at Dhule. And she has been mentored by Dr. Surendra Wargaonkar, who's the head of the department in ophthalmology there. Over to you, Dr. Savni. You can start.
A very good evening to one and all present here. Yes, am I audible?
Yeah. Please go ahead.
A very good evening to one and all present here. I am Dr. Savni Dole, second year resident. I'm extremely obliged to have this chance, and I would be talking about bridging the defect posterior auricular grafting for the aesthetic repair of lateral canthal tissue defect. Is the slide moving?
No, Dr. Samni. Is it moving on your screen? You can click that
Is it moving
forward
now?
button. No, yeah, it's moving. Please continue.
Okay. So talking about the basics, improperly corrected tissue defects in periorbital trauma can lead to aesthetic and functional deficits. So, and moreover, larger defects, especially in the lateral canthus, can be very challenging as the lateral tendon directly interacts with the bony tissue to determine the location and function of the eyelids. So normal positioning of the lateral canthus becomes really important for an aesthetically pleasing face, disruption of which leads to a cosmetically significant deformity. Plus, maintaining a natural eyelid contour is also necessary to avoid facial disfigurement. Ours was a case of 26-year-old male, came with history of road traffic accident 2 hours back, came with complaints of pain in the right lateral canthal region, forehead, and right temporal region. There was no history of head injury, loss of consciousness, ENT bleed, and vomiting. Past personal family history was not significant. Journal examination was within normal limits. Patient had multiple grazed abrasions on the body as well as face on forehead on the right side and right angle of mouth. At the lateral canthus, there was a deep contused lacerated wound with a central tissue defect, as in the image. It was triangular in shape, measured 4 into 3 into 3 centimeters with jagged edges at all the 3 vertices, and the defect was about 0.5 centimeters deep. The lateral canthal tendon was intact. Tissues lost were mostly the superficial fibers of orbicularis oculi muscle and skin. No bony exposure was noted, however. The wound also extended 1 centimeter on the upper lid. Ocular examination was within normal limits. We came to a diagnosis of traumatic right lateral canthal laceration extending on the upper lid with a tissue defect. CT orbits was done to rule out orbital fractures, which was not found. Wound was cleaned, irrigated with normal saline, TT was given, local wound debridement was done, and surgical management of the wound was planned. Under local anesthesia, the jagged ends of the wound were sutured with 6-0-ethylone. Some part of the laceration, which extended onto the upper lid, was sutured with 6-0-ethylone. However, the central large tissue defect still remained. So we planned a full thickness skin graft from the retroauricular area. Size of the tissue defect was measured for the same, and patient's left posterior auricular area was marked with a marker. Full thickness skin graft was harvested, and adjacent skin was undermined, and primary closure was performed without tension. The graft was then placed on the recipient defect. It was closed. The defect was closed with the graft using 8-0 Vicryl sutures. These were the pictures of the posterior auricular graft. The graft was placed and then sutured. It was covered with a Cuticell dressing, and oral antibiotics and NSAIDs were given. Patient was called for a follow-up after 3 days, but he failed to follow up. This picture is 1 week post-operatively, and then he directly followed up 4 weeks later. These are the pictures of 6 weeks follow-up, where we saw the healing of the graft without any apparent ptosis, and symmetry of the lids was also maintained. So there are various techniques for tissue defect repair, but they lead to unsatisfactory post-operative outcomes due to various complications. In this case, direct closure without tension was not feasible. That is why we opted for full thickness skin grafting to avoid cicatricial ptosis and distortion of the eyelid anatomy. as he was a young patient also, of course. The take-home message, even minor facial trauma demands detailed evaluation when it comes to area, especially in young patients. Presents to long-term complications like ptosis formation. So basically, skin can be an effective option for the closure effects. They lead to reduced chances of scar formation and ptosis. Closer monitoring and frequent follow-ups of these patients are required to prevent graft failure and infections. These were my references. Thank you so much.
Thank you, Dr. Savni. Very well managed and presented. Thanks to you and Dr. Vargaonkar. I would now request Dr. Roshmi to ask a question to Dr. Savni.
Well presented, Dr. Savni. If I'm not mistaken, you're probably the youngest presenter here today. And you kept up pretty well with everybody else. Well done. And I'd also like to commend you on the fact that you pointed out that the photographs have been used with the permission of the patient. So another well done for that.
Yes.
So what would be your different choices of skin graft sources for the eyelid in order of preference? What would be the best match for the eyelid skin and so on? Different donor sites. Here you use the retroauricular, yes.
As I have read, it can be, yes, as far as I have read, I'm not very versed with the best tissue that can be used, but it can be the skin of the other eyelid. It can be posterior auricular, preauricular, it can be clavicular. That is what I know.
Yeah, once again, well read. The best match is actually the eyelid skin. And then preauricular, but preauricular, there's very little tissue available. So thank you, Dr. Savni.
Yes.
Thank you, Dr. Roshmi. Dr. Mangesh, do you have any questions and comments for her?
Dr. Savni, you're doing residency there?
Yes, sir. Yes, sir.
She's a GR2, second year.
Yeah, GR2 second year.
I'm a second year resident.
Congratulations, you have presented very excellently. And as Dr. Roshmi said, what are the other choices, that they are the preauricular, postauricular, and what could be other alternatives for this? Means instead of going skin graft, what could be the other alternatives to manage or address this case?
Basically, if the tissue defect would have been smaller, there could have been direct closure with undermining of the skin and approximation. Then adjacent tissue transfer or flap reconstruction is also an option.
Okay.
Lateral orbital flap is also what I read about for the lateral canthal reconstruction. But
okay, good.
I'm not so sure about that.
Okay, so before considering the skin graft, the undermining of all the surrounding wound edges, was this option explored?
Yes, we did explore that option. We undermined and we tried to approximate the wound by doing it, but we suspected that it lead to a significant amount of ptosis and asymmetry of the eyelids. That is why we chose the grafting option.
Okay. One just additional point. Do you know what is laissez faire? Yeah. Can you tell me about the laissez faire? Laissez? Okay. Just one. What is the Frick's flap? A Frick is flap? Okay. Means leaving it alone. Laissez faire means leaving it alone.
About it.
Okay. Good.
Okay.
Good. Excellent presentation.
Okay, sure.
Thank you so much, Dr. Mangesh. Excellently mentored by Dr. Surendra Vadgaonkar. Dr. Vadgaonkar, do you have any comments for this
One can
case?
use amniotic membrane in this case. Yes, amniotic membrane. Because I am not oculoplastic surgeon, I am just peco surgeon and SICS surgeon. We are not doing that much work in our institute, but can we use amniotic membrane?
Sir, here actually we don't need any amniotic membrane here. The first choice in this case would have been the undermining the edges and the primary wound closure.
That is.
And you can have even the advancement flap from the upper side.
Upper side.
And if at all not possible, then we can think of full thickness or the split thickness graft. But basically, I think in this case, direct wound closure would have been the first choice, because we know even the fricus flaps, we are taking even the near about 4 to 5 millimeter flap from the lateral part of the eyebrow, and we are actually transposing it to the inferior part of the lid. So I think primary wound closure would have been the first option, and then all other options. AMT is certainly not needed even in all such cases.
We are thinking because we are using amniotic membrane in pterygium surgery. So I thought why not to use.
Surendra sir, I would like to congratulate you on taking on this case, basically because what we see in the residents in most of the centers, they are not doing anything for the eyelid injuries. They will refer it to the some of the institutes, but you attempted to take up this case and you try to cover up the lead defect or the tissue defect with the full thickness skin graft. So that is a commendable. So that is a great start. Congratulations.
Thank you. We are trying to do so many cases of trauma because here it is three highways goes from the Dhule city. So many trauma patient comes in our institute. We are giving primary management to them. And if we note that something is going wrong, then we refer this patient to higher center. And the higher center are not very close to our institute. They have to travel at least 300 to 400 kilometers. The people are reluctant to go in that place. They always say, why you don't do? Then we are giving opportunity to our resident to do under our guidance, and they are doing good things.
Keep it up, sir. Good work.
Thank you. Thank you for inviting me as a mentor. Thank you very much. And
Thank you so much.
there were excellent presentation today. I learned so much things. Even if I am HOD, so many things we miss because we are doing only basic things, cataract, glaucoma, and retina surgery. But oculoplastic is not our. Nobody is with us to do oculoplasty.
We are with you, Dr. Vargaonkar, and thank you for the commendable job. I think each of us who has joined today learned something new. And with this, we conclude our case presentation competition. And I would request all judges, starting from Dr. Joyita, to speak a few lines about this series and if there is any feedback. You're muted, Dr. Joyita.
Very exciting cases, very nice. And very, I'm just feeling very happy that all the cases are very well documented and the investigation has been done in a very systematic way. Okay. The first case by Dr. Yamini was very nice, and the other cases like the cases from Sadhguru, that is that sarcoid and endocrine mucin secretion sebaceous gland carcinoma. These are excellent cases, very well documented, and I congratulate Dr. Narendra for guiding our fellows so much. I was really feeling very emotional to seeing that that broad building, the very broad picture of that aerial picture of Sadhguru. So I miss that place a lot. It's a very nice place to learn. Thank you, Narendra. for
Thank
keeping
you.
all your effort. Thank you. And then the last case, Dr. Savni. Yeah. Savni presented. That is also very nice. But in my opinion, also, I think sir, primary repair by multiple layer would have been sufficient for this. In my opinion, but I was not there at that present, so it's very difficult to comment on. But still, it's a very nice effort, I'd say. Thank you.
Thank
Miss
you, Dr.
somebody?
Jyota, for joining us and giving your wonderful insights.
Yes.
Dr. Mangesh, any quick comments?
So thank you, Ayushi and Ananya, for this. This was a really great show. And I would like to congratulate your team and Dr. Puneet also. And you're taking the focused theme-based approach is really something new. And I would like to see many more things in the future. And I would like to congratulate all the presenters, Dr. Yamini, Devika, Yashodhara, Dr. Haik, and the Savni for their efforts and the excellent presentations. So whenever just I think whatever your this oculoplasty forum and the yo slides, I think we should have a more publicity and make it more public so that more and more people would be involved in this. It's a really good job. Keep it up. Thank you.
Thank you so much. We'll work on making it more popular for sure. Dr. Rashmi, any comments?
Well, congratulations to you, Ayushi and Ananya, Yosi, and all the presenters. They all presented so well. And I think this practice is useful to be brief, pertinent, yet cover all necessary points, document well. I think this is invaluable to inculcate this kind of a habit. Well done. Thank you. Thank you for having me as a part of this.
Thank you so much. And before we conclude this session, we have the most awaited announcement of the day, the award ceremony for the first session. Dr. Ananya, would you like to do the honor?
Yes, thank you, Dr. Ayushi. So this is the award ceremony for the last session on 29th of June. That was the first of the series on lacrimal system. So second runner-up is Dr. Martins, currently also a second-year resident in ophthalmology at OAU Teaching Hospital, Nigeria, under the mentorship of Dr. Bola Adebara. The team undoubtedly had a lifesaver, rare case, and we cannot wait to see it in print. Congratulations, Dr. Martins. Our first runner-up is Dr. Shivani Shadangi from GMC Nagpur, whose case was co-authored by Dr. Sagar and the presentation mentored by Dr. Shruti. And the trio made a very lucid presentation, and congratulations to you. And now we come to the winner, Dr. Priyadarshini Patil from Nandadeep Eye Hospital, Sangli, who talked about taming the flame in acute dacrocystitis and gave very useful points. She was mentored by Dr. Ayushi Agarwal. Congratulations to you too. And we would like to hear from anyone how this session has been useful to all residents and fellows.
Dr. Martins, are you there? Dr. Martins has joined us today as well from Nigeria. Are you there? Dr. Shivani, would you like to comment? Okay. Dr. Priyadarshini,
Yes, ma'am. Hello.
yes, you're audible.
I'm truly honored. Thank you so much, YOSI team and all the judges. And this session is very useful to all the fellows and residents. And we are learning new cases and approach to that.
Thank you so much. Dr. Martins has joined us. Do you want to comment on your experience? And congratulations.
Thank you very much. I'm very happy to have this opportunity to be on this platform. It has really helped me. The purpose to train residents to present in international forum, and for me, this happens to also be international coming from Nigeria, and I learned a lot from the section. The comments has also helped to further work on the presentation and prepare it for a publication in the nearest future. I want to appreciate my mentor, Dr. Adewara, for the insights and the opportunity to learn a lot from her wealth of knowledge, and the expert panel, the moderator, and everyone who has facilitated this program. It's been very helpful, and I learned from all the presenters too, and even from today's section. Thank you very much, Yosi.
Thank you so much for attending today's session as well. We have Dr. Rituja here today with us to share another wonderful upcoming activity from our focus group. Dr. Rituja, are you there?
Yeah, hello everyone. Thank you, Ayushi, and you had a very nice session. Really enjoyed it. Hearing Dr. Roshmi gave me a lot of flashbacks about my own presentations back in the day. Hello to Dr. Mangesh, Dr. Joyita, and Dr. Joyita will also be there next week in our YO TED webinar, which is a learning module in which we'll initially have case presentations by a fellow. And after that, they will discuss how to work up a case of thyroid eye disease, followed by presentations on eyelid retraction, surgical management, medical management, and even strabismus. So excited to have all of you all next week, and we'll take Dr. Mangesh sir's feedback and try to publicize this more by the time this one comes around.
Thank you. Thank you so much. Dr. Ananya, would you like to speak a few final words?
Yes, thank you, Ayushi. I would like to congratulate all participants from the previous and this session for such wonderful presentations, and congratulations to the winners too. Great learning points from all the expert panel. We thank you, Dr. Joyita, Dr. Mangesh, and Dr. Roshni. Great learning points from all the cases and mentors, Dr. Narendra Patidar, Dr. Sahil Agarwal, Dr. Prerna, and Dr. Vadgaonkar. I congratulate Devika, Yashodhara, Heg, and Yamini and Savni for their lovely presentations. We all look forward to Dr. Rituja's TD session. YOSI has put together a wonderful initiative, wonderful session here. Thank you to the executive committee and YOSI for this initiative. Thank you, everyone, and all our attendees who have been so patient and wonderful.
Dr. Ananya, can we have a good screenshot?
Yeah, so that's what I was coming. Can everyone switch on their videos and we make a mandatory YO sign for a selfie?
Mandatory, I like that.
Requesting everyone to switch on their videos. Dr. Haig, Dr. Martins, Dr. Ananya, can you take a screenshot? Yeah, we'll make the YOSI sign. I'm taking it now.
Yes. Thank you.
Done. Thank you. Thank you so much, everyone.
Thank you.
Thank you very much. Wonderful session.
Thank you and good night.
Good night.
Everyone.